All right. Good morning, everyone. I'm Elizabeth Cote, the Chief Health Officer here at NICHQ, and we're going to get started now. And good afternoon. Thank you all for joining us today. We know that there are thousands of people on this call, and we want to remind you that we are here as a resource for you, and we have a Q&A period at the end of the call. So if you want to send us your questions, we'll try to address them all. We know that breastfeeding is a topic you all feel deeply about, and mothers face so many different challenges when breastfeeding. If we can identify ways to help them open up about those challenges, we can do a better job of supporting them. That's why we've really focused this webinar on improving our approach to those conversations. Before we get started, a couple quick helpful hints. Again, we'll be taking questions at the end of the webinar, but you're welcome to add them to the chat box at any time. And before we jump in, I'm going to take a few minutes and tell you a little bit about NICHQ and why we're so invested in this topic. NICHQ is a nonprofit organization that for nearly 20 years has solely focused on driving dramatic changes in the complex issues facing children's health. Here you see our mission and vision. At the heart of what motivates us is the belief that children and families deserve better systems and supports so that every child achieves their optimal health. And at NICHQ, we don't just talk about making change, we make it happen. In more than 80 initiatives spanning 20 health topics, we've worked in partnership with multidisciplinary teams of partners, subject matter experts, communities and families like many of you on the call today, to build and execute strategies that drive improvements in children's health systems. This is just a snapshot of our current portfolio of initiatives. It has a variety of health topics and includes both state-based and national projects. You'll see one project in bold is specifically about infant safe sleep and breastfeeding. The National Action Partnership to Promote Safe Sleep, Improvement and Innovation Network is funded by the Maternal Child Health Bureau of the Health Resources and Services Administration and is focused on making safe sleep and breastfeeding the national norm. We've started with 5 pilot hospitals in 5 states and will be expanding to include additional hospitals, social service agencies, and child care touchpoints across the country. There's also a coalition of 70+ stakeholder organizations supporting the initiative. This project, along with our demonstrated history in the breastfeeding space, is what makes this webinar so relevant to us. For nearly a decade, NICHQ has been working to improve breastfeeding rates on a host of national and state initiatives. In all of these projects, NICHQ brings its deep content knowledge, nationally recognized expertise in quality improvement science, and experience in addressing social determinants of health and eliminating disparities to help more mothers and babies benefit from breastfeeding. But we can't do all this work without you, and especially without the leadership of some of the experts that are on this call today. So now I'm thrilled to introduce our first panelist, Dr. Lori Feldman-Winter. Dr. Feldman-Winter is a professor of pediatrics at Rowan University's Cooper Medical School and is the chair of the AAP section on breastfeeding. She has published extensively on neonatal and maternity care, especially regarding how health systems can best support safe sleep practices and breastfeeding. She is a current member of the AAP Task Force on SIDS, through which she participated in the process to develop the new 2016 recommendations for a safe infant sleeping environment. And she formerly served on the executive committee of the AAP section of breastfeeding as the Policy and Education Chair. Dr. Feldman-Winter currently works with NICHQ as the faculty expert on the National Action Partnership to Promote Safe Sleep. And in the past, she also served as the National Faculty Chair of the NICHQ Best Fed Beginnings Project. Thank you so much, Dr. Feldman-Winter, for joining us.
Thank you, Dr. Cote, for your kind introduction, and I'm very excited to be here today to introduce concepts of breastfeeding conversations. So what I hope to achieve in my portion of the talk is to help you appreciate the issues facing breastfeeding mothers today in the United States, to help you understand why mothers make a make different choices in their plans for breastfeeding and find ways to engage moms and families so that they're comfortable and confident in disclosing barriers that they face. And finally, I hope by the end of the session, you will identify at least one new strategy for engaging moms and families in breastfeeding conversations. U.S. moms face incredible obstacles that often prevent them from reaching their own breastfeeding goals. We know some of the common barriers, but even when it appears that things are going well, moms are often overcoming challenges every day in their breastfeeding lives. These challenges evolve throughout the timeline from prenatal to delivery, then after delivery, in the delivery hospital, and then after going home and out into the community. Each of these time points presents different sets of challenges. These challenges also differ depending on what moms and their families encounter in general with the healthcare system. So it's important that we create a safe space for moms to trust us, engage, and disclose exactly what's going on. It's important to recognize that most women in the U.S. do breastfeed. They intend to breastfeed and even continue breastfeeding. In fact, we have reached 5 out of 8 of the Healthy People 2020 goals for breastfeeding, with the only remaining goals yet to be met being exclusive breastfeeding for 6 months, where we're now just under 25%. We hope to exceed 25%. Any breastfeeding at 6 months, hoping to exceed 60%, and the percent of breastfed newborns receiving supplements in the first 2 days of life by mom's recall. The last one mentioned is one of the ways hospitals can help build supportive environments for breastfeeding. Geography matters too. As is reflected in this slide, the dark blue areas are states with the highest proportion of moms reaching the goal of 6-month breastfeeding, whereas the states highlighted in yellow have the lowest rates. I would suspect that if we did a similar map of ideal maternity care practices that support breastfeeding, and another one for community support programs for new breastfeeding mothers, the distribution would be very similar. In fact, disparities in race ethnicity are also seen differently as we move across the U.S. For example, when we look at overall breastfeeding, the map in the upper right-hand corner of this slide highlighted with the red rectangle, the South and Midwest show the greatest disparities between non-Hispanic Black mothers and non-Hispanic white mothers. And having worked with healthcare practitioners from hospitals in those regions, these disparities are consistent with the care provided, meaning that non-Hispanic white mothers get different care than non-Hispanic Black mothers within the same hospital and by the same healthcare providers. This is in part due to our implicit bias, and what we need to do is to recognize disparities in care so we can truly achieve equity. For example, I'm often told that if a mother requests certain evidence-based care, such as skin to skin, they do it, but normally they don't. So let's just consider for a moment who may be empowered to ask for certain evidence-based care and who wouldn't be. Mothers that are used to not having any voice in the healthcare setting may be the most difficult to engage in trusting, honest, safe breastfeeding conversations. Therefore, we have to consider an approach that works. The Lancet published a landmark edition on the global perspective of breastfeeding illustrated in this slide. When we think of a breastfeeding enabling environment, what components do we need to consider for early initiation, illustrated by the blue circle in the lower left corner of this slide? First, we must consider the mom and her attributes, her support system, and the relationship between her and her baby, and how this dyad and family are then supported by the structural components of the healthcare system and services that we provide or not. Within this paradigm, we must consider the hospital staff and how well they're trained in breastfeeding support and have adopted a culture where breastfeeding and rooming in is the norm, and they themselves are confident in their conversations about breastfeeding. And we know from our studies of pediatricians that while knowledge about breastfeeding may exist, confidence is often low. The literature tells us that these are the top concerns for mothers and why they stop breastfeeding before their intended time of weaning. The issues are in alignment with what more than 2,000 staff told NICHQ in a recent survey. The top 3 challenges staff face when trying to support breastfeeding mothers are lack of social supports, lack of breastfeeding role models, and supplements given in the hospital. And the top 3 challenges they hear from mothers are worried that the baby's not getting enough milk, the need to go back to work, and inability to pump at work, and the baby's not good at breastfeeding and seems to prefer the bottle. But behind each one of these mothers' concerns are underlying issues. So, for example, if a mom is saying that she's worried the baby's not getting enough, perhaps she doesn't really know the physiology of lactation and that it changes from the first days after delivery until the 3rd or 4th day of the baby's life. And also, if she's complaining that her nipples are sore and painful and that the latching her baby on is difficult, perhaps she hasn't been taught how to hold the baby and to help stimulate the baby to develop an effective latch to reduce the concerns and problems that exist within breastfeeding. So it's important that we think about the underlying issues each time a mom is disclosing any one of these concerns. Going back to the framework presented earlier, we can think of support strategies beginning first with the individual level. So, for example, belief that colostrum, because it's very low in volume, may not be sufficient, or that breastfeeding doesn't even matter until, quote, the milk comes in. So the first step is to really acknowledge this worry or this presumption that colostrum doesn't matter, and then provide the support and the education to give the clear indications of why colostrum is important, what's in colostrum, and what to expect in those early days. So it's really about becoming better listeners. And this is really about us, the healthcare professional. In my case, the pediatrician. As a pediatrician, how well do we listen? How well do we connect and provide a safe space that allows moms and families to disclose important information? We need to be better, or maybe different, in what we do to be better listeners and value what our patients are actually saying. This is a framework that I find very useful when helping to build these connections. This is called LOVE. And just like the acronym says, it's really all about the emotional aspect of making that conversation and that connection happen. So the first part of LOVE is just to sit tight and listen without any prompting. The second is to prompt by asking open-ended questions, things that begin with what or how, and then maybe even why. And the third, often forgotten or maybe not even considered, is to validate feelings. And it's through that process of validating concerns that are feelings that you think the mom is experiencing, such as worry or fear or anger or disappointment, that moms realize that you're really listening. And it's in that connection that you begin to open doors so that whatever educational points you have to offer at that point, it's heard, it's really understood, and it's more effective in really engaging in those open conversations. So we have to frame questions to be open-ended, and we're so used to framing questions to be closed-ended, to yield a dichotomous response, yes, no, bottle, breast, and things that are quick and allow us to check off checklists and documentation that gets us through seeing multiple patients. And we really have to begin to think about reframing the strategy for asking the questions in a way that in the end doesn't really take more time, but allows families to feel confident that we're really listening and listening in a non-judgmental way. Probing's okay. We can actually use extenders such as what else, or can you tell me a little more about how you feel about this concern? We can clarify. Don't be afraid to validate a feeling that you have a little suspicion about, but you're not exactly sure, because moms and families will correct you. They will acknowledge the importance of you trying to attempt to identify what the feeling is, and the connection is still there. So it won't be lost. It's not a lost attempt if you actually are wrong and identify a feeling such as worry that really isn't about worry, but really is about disappointment, for example. You can continue to probe by stating what you think you've heard, the same way that we actually use teach and reteach when we're educating patients. You can use the same principle by reflecting on what you think you've heard when a patient is actually discussing what their concerns are. So I think you're saying X, Y, or Z. Or besides what I think I've heard you say, does this bother you as well, or what else bothers you is really a better question. And then finally, padding. Again, different ways of making that connection by using a patient's name, by repeating their own words, by using pauses, and really what this webinar doesn't provide me time to do, but really engaging in the pause and the blank space to allow the audience, which is your patients and your families, to really feel that they have the time and the security and the trust and safety to be able to tell you exactly what's going on. So now I would like to turn my part of the presentation over again to Dr. Cote to introduce the next speaker.
Thank you so much, Lori, for that fantastic presentation. An important step that you reviewed in addressing the stark disparities in breastfeeding is simply carefully choosing the words that we use in our conversations with mothers. And now I'll turn this over to Suzanne Bronheim. Dr. Suzanne Bronheim is Adjunct Associate Research Professor in the Department of Pediatrics within the Georgetown University Center for Child and Human Development. She was the Technical Assistance Director for the National Action Partnership to Promote Safe Sleep, the first iteration of NAPS-IN. As faculty within the National Center for Cultural Competence, she was the director of the Sudden Unexpected Infant and Child Death and Pregnancy Loss Project within the NCCC for 15 years. Dr. Bronheim has provided training and technical assistance related to cultural and linguistic competence to state Title V and other public health programs, health and mental health care systems, nonprofit organizations, healthcare providers, family advocacy, and support organizations. Dr. Bronheim, thank you for joining our panel today.
Thank you so much. So how do we get to this idea of having conversations? Why do we keep reiterating and using that word? And part of it is, I think, that there's a need for us to change our mindsets if we're going to change the minds of the people that we'd like to influence. Most of us perhaps are experts about breastfeeding, or at least feel like we have some expertise about it. And we have a lot of knowledge that we want to impart. And we often talk about how can we find the right message. But the problem is that using that approach, which is kind of a one-way communication, is really not getting the job done. You saw the slides that Lori showed you. While we have a lot of people who are initiating breastfeeding, we have parts of the country and populations where we're really not getting through. And we really need a different approach, but it means changing our mindsets. It means changing from imparters of knowledge or experts to being partners in conversations with families. So things like population-based promotion campaigns are important because they raise awareness, and, quote, education, giving people the facts, does the same. But we really know from current thinking about behavior change that we have to have much more tailored interventions in these public health arenas. It can't be one size fits all, and it can't be unidirectional. Because families are the ultimate decision makers. They need to make informed decisions, and hopefully we can help them with that. And that deciding to adopt a new behavior based on multiple theories of behavior change says it takes place in the context of two-way communication, not just being educated or given information. So the conversations approach has some underlying assumptions. At the end of the day, parents and other infant caregivers are going to make those decisions. We first have to gain the acceptance of the caregiver to what we're trying to do. And we have to do it, as I said, in the context of two-way communication. Oops, not too far. So there are many theories about how to make change in behaviors. One of my favorites is Asians. And it's one that's actually been used a lot in talking about changing the behavior of healthcare providers. And we'll talk about that in a minute. But it has three components. First, somebody has to have positive perceptions of the behavior. They have to think it's a good idea. And not everybody may walk into your realm and think that breastfeeding is a good idea for a variety of reasons. And we need to understand those if we're going to help them move to thinking it's a good idea. Then others' beliefs about the behavior, Asian calls those normative beliefs, make a big difference. Whether it's family or the men in their lives, or we see hospitals, is there some kind of social pressure that's all moving them towards adopting this behavior? If there's not, we have to understand that and figure out how do we bring in some of that support and some of that, I don't want to call it pressure, but some of that energy to help them think this is not just you telling them it's a good idea, but pretty much everybody in their sphere thinks this is a really great idea. And then the last one, and this is so important for breastfeeding, you heard about all the worries that moms have from Lori. Their personal sense of, can I do this? Can I really make this happen? And if we only address the getting them to think it's a good idea, which is what so much of what we've done up till now is, and don't move through the other pieces and help them around thinking that they can do it and how they'll do it, then we're not going to be as successful as we could be. So for those of you who are visually inclined, here's a little diagram, but just want to say to you, this is actually what we're trying to do today on this webinar. We're trying to talk about your attitudes, help you think that this conversations idea is a great idea, even though it might not be what you've always done, although maybe some of you do. We want you to think that this is what everybody should be doing and is doing, and there's a lot of people out there working towards this. And then the last piece is that you can do this, and you'll get a chance to hear a sample of what a conversation sounds like. And at the end of this set of slides, there are some resources for you where you can go and go deeper into learning about this. So you can do it. You'll know how to do it. So just quickly, an example of how this Asians theory might play out in public health. And I'm actually going to use smoking since you guys all know breastfeeding so well. You know, we put out all the Surgeon General warnings on cigarettes, PSAs, all kinds of things. And there's probably not too many people who are walking around thinking, yeah, it's great to smoke, which is different. That was a big change. Then there's sort of the pressure, you know. Other people say, I don't want you to smoke in my house. Kids are begging their parents to stop smoking. We've outlawed smoking in public places. So we have that second piece. But it's not easy. So until somebody feels like they have the self-efficacy to do that, they're not going to be able to quit. So we have quit lines and smoking cessation programs and medications, things that make it so people think they could do it. So that's kind of another example. And Rogers, who's talked about this concept of diffusion of innovations, is very adamant that we don't get people to take on something new unless it's communicated in a two-way communication over time and through people in their own social system. So when we talk to families about what they need and why they do or don't adopt certain behaviors, one thing they talk about is they need the whys. They want to know why, not just be told to do it. They want to explore their doubts and their concerns. They also say they're not prepared. So when they face the challenges like sleep deprivation or problems with latch or whatever it is, they often give up on their intentions because they have the information that the self-efficacy piece hasn't been attended to enough. So we need to help families anticipate what might happen and plan for it. And that has to be part of our conversations with them, not just the what, but the how and the what ifs. So what might be different about a conversations approach? It actually welcomes reluctance, resistance, and challenges. It actually gets an opportunity to see what they're hearing out in the world, provides more information to address their reluctance, and it leads to a plan. So, how do we turn this theory into action? One is to even ask permission. Can we about sharing information? I know sometimes it's in your job and you have to check it off, but you at least might invite the person into a conversation about it, as opposed to, I have to tell you about this stuff. It's sharing information with explanations about why, not just what. And sometimes we hear from people saying, oh, you don't know the populations I work with. I just have to keep it simple. You just need to give them 3 simple things to walk away with. Well, that's really talking about what Lori mentioned as our own implicit biases, and that everybody deserves to have all the information so they can be informed decision makers and make informed choices. And it's our job to figure out how we can communicate that information in a way that works for whomever we're face to face with. We have to ask them, they've heard this before. What else are they hearing? Because, you know, Lord knows there's a lot of things floating out in the world, the internet, everywhere, about breastfeeding that may not be what we would like them to hear, but they're hearing it. And so we have to know what they're hearing about so we can talk about it with them and share some other thoughts and some other information. We have to ask caregivers if they plan to do this, you know, not just assume. I often used to go to the dentist, and every time, you know, talking about Lori and open-ended questions, they say, so you floss every day? And I'd always go, oh, sure. You know, one day, actually, the hygienist said to me, so how's it going with flossing? And I said, well, you know, to tell you the truth, I have this bridge work and it's not so easy. And she said, oh, well, then let's talk about that. And she came up with a plan with a water pick and some other things that works. But without that two-way conversation and kind of asking about it in a way that was not just yes or no, I would never have gotten there. Also being able to talk about what they don't want or feel they can't do so we can give them more help or support. I mean, you know, they may say, okay, I might try this, but as soon as I go back to work, forget it. They may have some other concerns. But if we don't know what their specific concerns are, we can't give them the information, support, and help them plan about it in a way that might be useful. And there's a link here. This is part of the conversation modules that were developed by the last iteration of NAPS, and there's a link to the whole thing. But this is just a whole list of things that you could print out for yourself to think about, you know, when somebody brings up an issue, some information for them that's been vetted. Then some problem solving. To find out, well, how much could you do? Could you do it in pump? You know, could you do it for 3 months? Whatever it is, and offering ways to figure that out with them, how they could get to what they want to choose. And then the last piece is creating a personal action plan. How are they going to sleep and feed their babies? What do they think might come up? Who can help them? I mean, if they haven't slept in 3 nights, is there someone they can call to come over so they can take a nap? If they're having problems with breastfeeding, where do they turn for that? Having that plan. Now, that plan can change over time, and part of the plan might be, who do they talk to? If they think, you know, I thought this would be how it was, but it's not, I need to plan something else. So I know there's those of you who are sitting and listening to this thinking, really, there is no way I have time to do all of that in the short time I have with folks that I'm working with the moms and the families. And we recognize that. So we think that there's some different roles that people may play in this conversations approach. What's really, really important is your mindset. You may not be going through every step of the way, but it's that idea that it's going to be a two-way communication and that it's not going to just be you sharing information, but you eliciting and hearing from the families. So some of you may be conversation starters. You don't get much time. You might have a one-time or limited time. You can introduce the information. You can find out what their questions or concerns they are. You may not have time to address all that. But at each level, there has to be a plan. Now, the plan at that level might be, all right, let's plan who are you going to talk about this more. It means that you have an obligation to not just know the information, but to know the resources that are in your community, are there for families. They might be real people, they might be virtual, whatever it is. So you can make that handoff, hopefully a warm handoff. There are conversation deepeners. So if you have a little more time, more ongoing interactions, but really some limited time, you can delve into their reluctance, give them more information about misconceptions, help them think about the risks and benefits. And then there's some of you out there who I'm hoping are going to be what I would call ongoing dialoguers. You have an extended interaction over time. You might be working with them in a WIC clinic. You might be a home visitor. You might be a doula. I mean, you may have various roles, but you have time and you're going to see them over time, before the baby, maybe after the baby's born. And really that's who can help them develop their detailed plans, to connect them with the resources and help them deal with the challenges. So I'm hoping that with our short amount of time, we're going to help you think it's a good idea, help you think that this is really where we need to be headed and what lots of people are doing, and in a minute give you a taste of it and then some resources so you think, I think I could do this. Because first and foremost, it's a shift in how we think about our roles, and first we have to change our minds. So thank you, and I'm going to turn it back over now to Elizabeth, and I think we have a nice role play coming up for you.
Yes, thank you so much, Dr. Bronheim, for educating us on the conversational approach. Again, just a quick reminder to folks listening that we will have a Q&A at the close of the webinar, and everyone who registered for the call will receive a recording of the webinar with the slide deck. Both Drs. Feldman, Winter, and Bronheim have provided us with some important strategies for helping mothers open up about the challenges they face while breastfeeding. When I think about the number of conversations that the over 1,300 people on this call have with new mothers, I'm hopeful that our time together today, as brief as it is, will result in many more mothers connecting in the ways that they need to feel successful breastfeeding, no matter what their ethnicity or their geographic location. So let's switch now to a short role play so that you can see what these approaches look like in action. I'm going to introduce our role play participants. Rebecca Hendrickson is a breastfeeding mother of 3 and a La Leche League leader and peer breastfeeding counselor since 2012. She has significant experience working with mothers to support healthy breastfeeding practices and has been involved as a mother partner on NICHQ initiatives. Lisa Bailey is a peer counselor at the Lactation Care Center WIC program in Dallas. She's been trying repeatedly to connect with us throughout this webinar, but some tech restrictions on her end have prevented her from joining us. So I'm going to step in and play a worried new mother trying to breastfeed, an experience not so far from one that I have lived. And Rebecca will be playing the role of a lactation consultant. This scene takes place in a hospital the morning after delivery. Welcome, Rebecca. We're going to dive into our role play.
Well, good morning. I'm Rebecca. I'm the lactation specialist here. I'm so excited to meet your new baby daughter. Oh, she's beautiful. She's gorgeous. How are you both doing today?
Well, we had a pretty good night. She seems like she's nursing, but she is crying a lot. She stayed with me all night, but neither of us got any sleep.
Oh, that sounds like last night was hard. I'm glad that baby was able to stay with you. It's very important for breastfeeding, particularly, but I hear you saying that it was really tiring.
Yeah, I tried so many ways to quiet her, but she kept wanting to nurse. I'm not sure if I can keep this up.
What makes you unsure?
Well, I didn't expect her to cry so much. It seems like she's hungry even when the nurse says she's sucking. Maybe I'm not making enough milk. It seems like if she was full, she would sleep.
I understand. That sounds very hard, and I understand why you would be worried. Is that correct? I'm hearing that you're worried that you aren't maybe making enough milk for her, or maybe that she's not nursing correctly. She doesn't have the hang of it yet.
Yeah, I'm worried about both of those things. I just want her to be healthy.
Of course you do. I can already tell you're such an amazing mom. You care so much about your baby. You know, many moms worry about making enough milk for their babies. That's a very common fear. And I also want to tell you, I hear how tired you are after last night. You know, often on the second night of life, babies are just getting used to really waking up, being outside of the womb, and it's normal for them to wake up a lot. They actually need to nurse more often in these very early days because their stomachs are so tiny. They're about just the size of a cherry. And the milk you are making right now is something so important. Colostrum, we also call it liquid gold. It's kind of the superfood that babies need to be healthy and happy outside in the world now. And believe it or not, the more she nurses, if her latch is good, the better right now. But I hear your worry, and I'm wondering if it's okay if I watch her nurse and just check to make sure her latch is good.
Yeah, that would help me feel better.
All right, so let's bring her to the breast. Oh, look at you. You're already a pro. Look at that. You're doing great. And so is she. Look, she's perfect. Her latch is wonderful. It's a nice deep latch. Her lips are flanged. And do you see how her cheeks are not pinching in?
Uh-huh.
And if you hear that sound, that's a perfect sound that shows she's swallowing. And watch her jaw there. It kind of drops down, her lower jaw, then it pauses and it goes right back up. That's a perfect swallow.
Really? That makes me feel
better. All right.
Okay.
I'm looking at you. I see you seem a little more worried. Can you share more with me?
Well, you're not going to be here after you leave. And I was just thinking that, especially when I go back to work in 4 weeks, I don't know. I mean, it's nice that you're here right now, but then maybe a bottle would just be easier. That way I could really see how much she's getting. I won't be able to pump at work. So really, what difference does it make if I breastfeed for 4 weeks or not?
I understand. Exclusively breastfeeding, even for just a few weeks, can make a huge difference for your daughter's health and give her amazing benefits. I am hearing that you're worried about working and breastfeeding. Is there any way I can help?
If you think it really makes a difference, I suppose I could, I'll try. I clearly want to do what's best for her, even just for 4 weeks. I just don't know what I'm going to do because I have to go back to work so soon and then I'll have to stop.
It's hard. It's hard that you don't have a lot of time off. But am I right? And it sounds that you want to keep breastfeeding once you start work, but you don't think it might be an option for you?
Yeah, I guess yes and no. I do want to breastfeed. I'm just pretty sure my work doesn't have a place I can pump, and I don't know how I'd find the time anyway.
I understand. Going back to work and pumping is super challenging. Most people, though, they don't know this, but there are laws that protect the time and space you need to pump while at work. They actually have to let you do that.
I've heard it's a law, but I still don't think there's anywhere in my work I could go. I don't know if they know it's a law, and I don't know who to ask.
Okay. So you're right. All states have laws that require your job provide a place to pump, and they have to give you the time to do so. And I can help you connect with more support so that you feel comfortable talking to your employer. Maybe we can help you find who exactly it is at your work you need to talk to and what the law says, so you can tell them that.
It would really help if you could help me understand what I should say to them, who I should talk to, maybe even talk to them. Especially no matter what, I would like to breastfeed her before and after work. How about in the middle of the night? Wouldn't that be easier? I have to get some sleep though. If she's still hungry, how else can I get her to quiet down in the middle of the night?
Yeah, well, especially after last night, I can understand why you might be worried. It sounds like you're tired. I can show you some ways to help with that if you'd like. First, you could do skin to skin when you're awake. Just being on your chest will soothe her. That's really her home now. Let's see, how else can we find ways for you to get a good start breastfeeding but not feel so tired?
Well, what happens if she still won't sleep? How am I going to go? How am I going to get any rest between breastfeeding and her crying? One of my friends suggested a white noise machine. Is that a good idea?
Yes, white noise can definitely help to soothe fussy babies. And limiting visitors, especially in these early days, so the baby isn't overstimulated, can really help. And I know that's hard. Everyone wants to come and see the baby, but your rest is so important and just your special time with her. And I can suggest keeping the bassinet near your bed so you can easily feed while you're still in bed. Many moms I've worked with also find it helpful to not lay the baby down immediately right after a good feed. You can hold her slightly upright on your chest until she is in a deeper sleep. So what that looks like is her breathing will be slow and regular, and there won't be all that movement under her eyelids. They'll be fairly still. And then after that, to try transferring her then to the bassinet.
Okay, that makes sense. I hadn't thought of some of those things before. I mean, I guess you never know what might work once you get home, though.
Well, that's true. Do you have someone at home to support you?
Well, my mom will babysit when I'm at work, but I really don't have much other help. And I know I'm going to keep having a lot of questions.
It sounds like you're worried about who to ask, maybe, if you have questions when you're home. Is that right?
Yeah, I'm totally worried once I leave here, I won't have enough support.
I hear that. I know this can be overwhelming. Why don't we think about who you can call when you have questions or feel unsure? I know of support people here at the hospital that you can still contact once you're discharged, so even after discharge, as well as some wonderful support groups in your community, like your local Women, Infants, and Children office. There's also the NICHQ League, Breastfeeding USA, wonderful folks that can really help you. And that way, even when you're home or it's late, you can always get the help and backup you need.
Okay, Rebecca, can I call you?
Sure.
Thank you. That brings our role play to a close. Okay, thanks, Rebecca. So this is Elizabeth. I'm going to transition back to my facilitator role at NICHQ from acting as the nervous mom that I am in my other role. And we're going to take some questions now. This approach that we just shared and tried to demonstrate helped moms share 3 different concerns: not making enough milk, how to balance breastfeeding and work, and how to manage sleep habits for mom and baby. By helping me share concerns, Rebecca was able to provide helpful, relevant resources and advice. So now we're opening the floor up to questions. Please type them into the chat box. And if you'd like them to direct them to a particular panelist or role play participant, you can mention that in your question. To our wonderful experts, Dr. Feldman-Winter and Dr. Bronheim, thank you so much. And please remember to unmute your microphone to respond. Again, I'll remind everyone that you're going to get a recording that includes the slide deck if you've registered for this webinar. So we've had questions come in throughout the webinar, and we're going to start here. How can we get more expectant moms to prenatal ed classes and better birth preparation that will lead to better outcomes? So if our panelists could unmute their their computers, and I'll repeat the question. How can we get more expectant moms to prenatal ed classes or get them the education that they might need? How can we prepare them better for birth so that it'll lead to better outcomes?
So this is Dr. Feldman Winter, and my response to that question, it's an excellent question, because we know from the evidence that moms that come to the hospital prepared for what they're going to see in the hospital, particularly around the 10 steps to successful breastfeeding, and then really the knowledge and skills about how to breastfeed, are more likely to initiate and continue breastfeeding. So that was all validated in AHRQ, or Agency for Health-Related Research and Quality Review. So prenatal is very important. And my response would be to go where the mothers are. Very often we run prenatal classes or breastfeeding classes, and so that's an additional activity that we're asking really busy pregnant moms to engage in, and sometimes that's just not possible, particularly for working mothers, because they're trying to save up days anyway so that they can have a longer maternity leave, and so it's hard for moms to actually engage in extracurricular activities in the prenatal period. But my hope is that they are going for prenatal visits with their maternity care provider, their OB or family physician. And so the more we can integrate breastfeeding education in that environment where the moms are, the better we are in achieving a mom who's aware and prepared and feels that she has had adequate time to engage in these conversations in the prenatal period.
Hi, it's Dr. Bronheim. So you're talking about a behavior change. So if we think about our model, what are the three things that we have to make sure happen? One is that people think they're a good idea. And truthfully, word of mouth can be a wonderful way to get this going within a community. Once you have something going that somebody says, when I went to the doctor's office, I stayed a few extra minutes and they had this wonderful person and it was really great. If you don't have the direct word of mouth, figure out other ways to do it, have people suggest it, have caregivers suggest it. Secondly, make it it's more of a norm. So if it's part of a visit that everybody's doing it, get word out into the community with other moms, with the grandmothers, with churches, with other people in the community, this is something we should be doing to make sure our babies are healthy. And the last one is the self-efficacy. Can I really do it? And I think Lori talked about that. People aren't going to have the time to say, oh yeah, I could do this. I could show up another evening a week. We have to figure out how we make it work for them so they feel they can do it.
Thank you for your responses to that question. Here's another question from our attendees. How do we address drop-off during the postpartum period of mothers who have expressed the desire to breastfeed? So for moms that want to breastfeed, how do we address drop-off during the postpartum period?
Well, it really begins in the hospital, because moms that leave the hospital exclusively breastfeeding and have good early follow-up are more likely to continue to breastfeed, do any breastfeeding, and also to continue to exclusively breastfeed, which is what our goals are. So the support begins in the hospital with the 10 steps, as I mentioned earlier, but then really important that moms have the opportunity early on to engage in conversations, but then really are confident about making that connection with community support once they go home. And that can be at the pediatric office practice, although I did see a lot of the chat talking about pediatricians being the ones to quickly introduce infant formula as a solution for breastfeeding problems. And that is a challenge, and I acknowledge that we have work to do with pediatricians so that they can learn the same techniques we're talking about on the call today, and to stave off the temptation to introduce formula as a solution when it's not medically necessary, and then have wraparound support that is available in the outpatient arena. So support, I saw also a lot of chat around nurse-family partnerships, which can be extremely helpful in communities that have strong nurse-family partnerships, where moms welcome nurse allies into their home and can provide that clinical support as long as they're trained. And I saw a question around that as well. So I think it's important that our community health providers are trained in breastfeeding support. And really, it doesn't matter what credential you have. It doesn't matter if you're a physician or an IBCLC or a CLC. I think every clinician or any healthcare provider in general has a certain level of basic skills to be able to engage in these conversations, and really redundant support that's consistent and evidence-based is really better than no support at all. So I think we have to each support each other's discipline to be able to step up to the plate to all consistently engage in conversations and really tidbits of education that sounds alike, that we're not contradicting each other and we're really all supporting each other, so that the mom really does feel that there's this network that's communicating on her behalf. And really the best communities and as I've always heard, problems that are about the community are often solved within the community. So really thinking about every different community. You've seen one community, you've seen one community. So every community has to get together and find their own solutions for weaving that network of support among all the different providers that can all be taught how to engage in these conversations.
I would just like to add, when we get frustrated with some of our colleagues, again, to think about the model, because rather than just finger pointing, it may be that they probably think it's a good idea, but the whole self-efficacy thing, do they really have the knowledge and skills, and do they feel confident and comfortable really supporting breastfeeding? Maybe, maybe not. So maybe some conversations with our colleagues around that and helping them develop a plan and how can we support them, rather than just saying, they don't support breastfeeding.
And this is Rebecca. I also just want to encourage it. Part of the 10th step is to connect moms or families to community support. And studies have shown that peer support makes an enormous difference in breastfeeding duration. So, whether it's the WIC group, local community group that's meeting in a library for breastfeeding, La Leche League, Breastfeeding USA, there are a lot of peer support groups that are trained peer breastfeeding counselors that really have high impact.
Thanks, Rebecca and Drs. Bronheim and Dr. Feldman-Winter. We have time for 2 more questions. The next one builds on the last. What challenges should we help moms anticipate? What specific challenges should we help moms anticipate?
I think one of the most significant challenges for women early after delivery, after going home from the delivery hospital, is the concern around return to work. And we have some, very few states that have paid maternity leave. I think that the states that do have paid maternity leave do so because of the coalitions that exist within those states that have really worked hard to get that legislation. But I think that there's a lot of concern about how to make that transition. So without paid maternity leave, many mothers return to work really soon after going home from the hospital. And while those moms can be supported to breastfeed and to express milk so that the baby can be provided mother's own milk, I think that having a really solid network of support for moms as they transition back to the work environment with all of its stress and expectations is really one of the top concerns, in addition to all the other sort of physiologic concerns about the baby's weight and growth, and the mom's concerns for latch and nipple pain and things like that. I think that's where all of the different providers and I have to agree with Rebecca that peer support is essential in that environment, because peers can really have been shown time and time again to really help support mothers get through specific challenges. But I think that one of the most significant challenges is thinking about that return to work and how to navigate solutions to support the mom's continued breastfeeding, whether it's on-site childcare or ensuring that the workplace enforces the laws that are in place by the ACA so that the provisions are made for her to be able to express milk at work.
This is Dr. Bronheim. I think following up on that, a significant challenge for a lot of mothers is not having natural networks of support that are supporting them in their breastfeeding and even in bringing a new baby home. And that's why finding these community networks and resources that can create a network for the mother is very, very essential and part of our work.
So following up on that last point is our final question. I want everyone to know that we will do our best to address all the questions that came in the chat box in time. We can connect with you personally, and don't hesitate to reach out to us with any questions. The last question is about finding mothers and reaching them when they don't have peer support networks. In places where transportation is limited or in rural communities, when you might be working via telephone with breastfeeding moms, how do you establish trust and rapport, and how do you employ this conversational approach?
Can I speak to that? This is Rebecca. Just because I do a lot of breastfeeding support via internet and telephone, actually probably the majority of my work is in those forums now because fewer and fewer families are physically attending meetings. It's being seen all over the country. I think, again, the same love approach is essential, making a connection, asking open-ended questions, acknowledging their feelings. I mean, I acknowledge, validate, and that seems to open the floodgates both on the telephone and online. I have moms break down in tears all the time over the phone, just asking those open-ended questions, or me just saying, wow, that sounds really hard. And, and then it all comes out.
So I completely concur, and I just returned from the American Academy of Pediatrics meeting where one of our programs, educational programs at the section on breastfeeding section program was on telelactation. So that is the new wave of how we provide care is through telecommunication. There's now state laws that garner all of the nuances and how that can be done, but I agree. The love conversation paradigm is key, even in telelactation counseling and really any kind of telehealth. I think it's even more important that that you use a technique to engage in conversations. And I like to say with love, this is one thing that you should try at home. For example, honey, it sounds like you're really angry that I didn't cook dinner tonight. Something that, and you will be surprised how well it works. Just acknowledging feelings, from the people that you care about and care about you.
Well, this is Elizabeth at NICHQ, and I felt very validated in my telecommunication with Rebecca. So I hope that everyone on the call, the panelists, and the over 1,000 people who joined us feel validated and honored as well, that your work is important and we're all trying to help each other improve, especially so that we can address disparities. Again, we want to remind you that the slides and the recording will be sent to you, and we'll do our best to address your questions, even if they weren't repeated during the course of this webinar today. I'd like to thank our panelists, Dr. Feldman-Winter, Dr. Bronheim, Lisa Bailey, who was with us even though she couldn't connect with us, and Rebecca Henriksen. Thanks to all the NICHQ staff that worked hard to put this webinar together. And especially thanks to all of you who are doing the work on the ground with the moms or through the telephones to help each mom feel validated and to connect in the way that she needs to feel like breastfeeding is a success, no matter what her ethnicity or what her geographic location. We want to be sensitive to people's time, so we're going to wrap up. But again, let us know if you have any questions. Thank you all.
Thanks and have a great day.
Goodbye.
Bye.